By the people, for the people, the gathering to get health care now. Chapter 7. Insurance Pools and Trusteeship. Patients who are beneficiaries of Medicare, Medicaid, employer-sponsored trust, or private insurance can combine with the PPC group association plans with the concierge payment plans, and the result is better access to care and lower medical loss ratios. Physician associations can also form their own health maintenance organizations to contract with Medicare, Medicaid, and employer-sponsored trust to be plans through which the patients will have coverage and service advantages. These service plans should be able to have lower administrative burdens than the 15% usually charged by the currently competing HMOs. At least, if there's an administrative profit margin, it can be shared with the patients and the physicians. The fundamental changes needed in the healthcare system are in the areas of education, trusteeship, and proper incentives for physicians who advise and treat patients. An educated patient's point of view about his or her health care could be a desire for help when needed and avoidance of harm at each encounter. The knowledge and skill of the physician is the main concern, even if their personality does not match well with that of the patient. Since physicians are trained in many different types of practices, the patient, for reasons of economy, should pick a primary care physician within the type of practice that suits the patient's wants and needs. Since the patient is paying directly for these services in a private agreement with the physician, that choice has little or no impact on the financing through insurance or other types of care needed episodically. The way in which the system will maintain health is by the diversity of its interconnections and the capacity of its members to share information and labor. The cost of care for any group will be commensurate with their needs. The greater the care capacity of the organization, the more likely they will be to maintain health and control their economy. Healthcare costs in the U.S. are double that of almost every other industrialized nation because of patient ignorance, corporate greed, bad laws, and regulatory policies. Oddly enough, patients can fix these kinds of problems rather quickly by joining together locally and teaching each other medicine, finance, and good trusteeship. As an example, should an educated old person subject themselves to extreme medical care and surgeries in the last few weeks of their life? And what guardians would allow that to happen? It is unfortunate that sometimes the decisions about medical care are vested in those whose lives are not seen in the context of their time and condition, but in the imaginary time of their caregivers and their younger relatives. The saying, "First do no harm," begs repeating. Yet doing nothing is contrary to nature, even when it's right. The record of more than 400,000 people per year killed by medical care in hospitals is the mark of our wrong notions about the needs of patients. People want to live a long life, but in good health, free of pain, and independently. So good medical care is advice and treatment leading to those conditions. Measuring the quality from people other than patients are checks on the skills of physicians by his or her peers. And they're important, but do not necessarily improve care for a particular patient. They only measure it and educate the caregivers. Financing healthcare requires cooperation, first between the physician and the patients who regard him or her as their primary care provider. Then second, between all the patients and the primary care physicians in the community. In the first case, the patients of a physician support the practice, and the physician makes time for all of them. This does not rise to the level of needing to be shared in a larger population to be affordable to each patient. In the second case, the patients need to pool their money to be able to pay catastrophic losses. They need a qualified nonprofit association to purchase group insurance that would be all inclusive of their needs. If their group were large enough, they could possibly form their own company for this insurance, but usually that is unnecessary and more expensive. Within cooperatives, trusteeship of the money is the central issue. The predominant system in the USA is broken because the trusteeship is poorly structured and corrupted by transfer of ownership of the trust funds to third parties. This transfer allows money that was intended for healthcare expenses to be converted into inflated administrative expenses or corporate profits. The Medicare trust funds could be an exception to that transfer, except the payment system in Medicare is based on fee for services or derivatives of that, such as bundle payments or capitation. The consequence of this is a faulty payment system in which trust funds are simply plundered by frequency of use of unnecessary services that are very difficult to challenge by regulators. Also, the distribution of the Medicare funds is handled by contractors who benefit from the volume of transactions they process. So the Medicare trust funds are not really in the hands of trustees in a practical way. In the case of premiums paid to commercial insurers by individuals, businesses, Medicare, and Medicaid, those funds become the property of the private company, and what they have left from the premiums belongs to that company as an underwriting profit. The healthcare law, PPACA, has attempted to address the unfairness of this by limiting the medical loss ratio to 85% of group business and 80% of individual business. It's not universally applied, and it can be manipulated by the companies. 15 to 20% is a large percentage of the premium for administration and marketing when compared with other financial management, especially when compared to the 2 to 3% paid by self-insured large employer groups. The solution is for the funds of the patients that can be budgeted and paid directly to providers to be pooled in a trust fund that pays the lowest administrative fees and returns the balances from claims to the trust. Those funds can be returned to patients and shared with their physicians as incentive to get better care and not waste money on unnecessary services and supplies. This is the best of times for taking control of healthcare systems because it's inflated and wasted money can be applied to correct both services and distribution of funds. There are few, if any, barriers to correcting the payment and delivery systems when it's being done for self-identified groups of patients and physicians. The shrinkage of the funds will affect unneeded medical services and overpriced administration. The potential financial gain for the patients and physicians is to substantially lower the cost for patients and to increase the revenue for their chosen physicians.